All right, so welcome everyone to our weekly Wednesday morning orthopedic surgery grand rounds. Today I have the honor of introducing Dr. Sarah Stroud. So Dr. Stroud is one of our fourth year residents here at UCSF. She did her undergraduate work at Princeton, post-bac at Columbia, and then medical school at SUNY Downstate. She then came to UCSF for her residency. She has performed research in oncology, trauma, upper extremity. She has been recognized by the OREF with an award for her research. She's also been recognized multiple times for her excellent clinical care, including receiving the Crevens Award and then the ED House Staff of the Year Award from the Parnassus Emergency Room. She'll be speaking to us today about access to care in orthopedic surgery. Dr. Stroud is currently applying for a trauma fellowship with plans for an additional hand fellowship after that. So Dr. Stroud, thank you for presenting today and look forward to your talk.
Thanks, Dr. Lansdowne. So I'm Sarah. I'm one of the PGY4s. I'm going to talk about access to care, so access and outcome inequities in orthopedic surgery. A couple acknowledgments here. So thanks to Dr. Westrak. She's a PI on our OREF grant research in extremity sarcomas. Thanks to Dr. Theologius, who is the PI on our spine sarcoma research, which is cited at the end of this talk, and some current attendings, former residents for inspiration. So Eric Geiger, whose spine sarcoma project I inherited, Heather Roberts, Dr. Ward, who do work on access to care in arthroplasty. I'll cite them several times later. We'll talk about it, but about distance traveled to arthroplasty care. And of course, to my test audience, Clay and Ramona, who have heard this talk like 16 times. So no disclosures other than the OREF grant over the last academic year for the extremity sarcoma work. So I have structured this talk as follows. I'll give just a brief demographic background about the way that race, income, and insurance status interact in the United States. They are very interrelated. They don't exist in a vacuum. And I think it's important to have sort of a numerical vocabulary for how those things interact as you are examining them in medical literature. I'll touch on my search methods. And then one of my hypotheses going into this talk was that trauma care, or the more urgent, less elective specialties like trauma and onc, would have a different clinical paradigm that may, in some cases, equalize certain clinician biases or other bias factors that might exist in the more elective specialties. So I've broken down the review of access and outcome inequities into the elective specialties individually, and then trauma and onc. And then we'll touch on what conclusions we can draw and targets for future research. So my goal in giving this talk is not just to catalog bad news, which does exist, but to start to look at suggestive correlations and potential mediating variables that can be targets for intervention. Obviously, we can't determine causation in the literature as it stands for some of the outcome disparities that we see, but I think we can start to identify which variables may be the most important mediators to target for interventions and research. So just a brief overview, this is census data. So the United States is about 3/4 white, about 13% Black, about 19% Hispanic or Latinx, and about 6% Asian. And those groups are very heterogeneous, and this is self-identification on the census. California is a lot more Latino than the United States as a whole. It is less than half of the Black population nationally, so 6.5% of California residents are Black. And then San Francisco is about 1/3 of residents who identify as Asian. It is about 5% of residents who identify as Black in San Francisco. That number is down from a nationally representative 13% in 1970 to less than half that number now. And so just sort of gut check numbers as we proceed through the talk. Demographics within orthopedics. So on the whole, 5% of practicing US physicians are Black, 6% are Hispanic or Latinx. This is from the AAMC. 56% are white. There are multiple studies in both medical and surgical literature that suggest that we are the least diverse of any specialty. In fact, I know that sometimes we like to point fingers at neurosurg, but it is us in several investigations, and that actually worsened from 2006 to 2015. I don't have data from the last 4 or 5 years. There may be more hopeful findings there, but it's a little bit bleak when you look at it this way. You can see that 2%, under 2% of practicing orthopedists are Black. For those who are curious, over the same time period, our percentage of female residents increased from about 11 to about 15 or 16%. For context, other surgical subspecialties increased to the 30s and 40s% at that time. So general socioeconomic status numbers in the United States. So the median household income is about $63,000. California is richer at $75,000, and San Francisco richer still. About the same percentage of people live in poverty in the United States in California, and in San Francisco about 10-11%. Income is not distributed evenly by race. You'll see here that Black Americans have the lowest median and mean household incomes and the highest percentage of people living in poverty, which at the time of this census data was about $18,000 per year. Hispanic Americans have the next lowest median and mean household incomes and the next highest percentage of people living at or below the poverty line. You can see that the percentage of Black Americans living below $15,000 a year is nearly twice that of the total. This is data from after the passage of the Affordable Care Act. So in 2019, about 8% of Americans are uninsured. Of those insured, about a third are on public insurance. About a fifth of those are on Medicaid. And insurance status does appear to vary with race. So you can ignore the multicolored dots. Basically, the dark blue dot is what we're looking at. This is percentages of people in each race covered under public or private status. Black Americans, followed by Hispanic Latinx Americans, have the highest percentage of people on public insurance and the lowest percentages of people on private plans. And this is just Medicaid beneficiaries by race in the United States and in California. You can see that white Americans are underrepresented on Medicaid. Black Americans and Hispanic Americans are overrepresented nationally among Medicaid beneficiaries. In California, the percentage of Black Medicaid beneficiaries is proportional to the percentage of Black Californians, but Latinx Californians are overrepresented in California Medicaid beneficiaries. As we start to move into what we see in the medical literature, we know that life expectancy does vary by race. So Hispanic Americans have the highest life expectancy at 82 years from birth, white Americans at about 79 years from birth, and Black Americans the lowest at 75 years from birth. There is a sexual dimorphism in each race, with women living longer than men. And just obviously this could be like 6 talks, just this slide, but I wanted to give a few suggestive points from other areas of medicine that were sort of the genesis for questions I had in this talk. So there's a very significant Black infant and maternal perinatal mortality gap. So Black infants have 3 times the mortality rate of white infants. There's evidence that race concordant care is beneficial and ameliorates 60% of that mortality gap in infants, not in mothers. So that has been done between Black and white mothers, and race concordant care hasn't shown a benefit, but it does in children. We know that mortality among certain cancers is higher in Black women, in low-income women, in publicly insured women. And there's some evidence in the breast cancer literature that Black women have access to, and Latinx women have access to, lower quality mammography screening machines, which may contribute to things like presenting to care at a later stage or time from symptoms to diagnosis. And then hitting a little closer to home, we see that Black women are 40% less likely to be referred for DEXA scan than white women, even at the same low weight class, even after a hip fracture. So my questions for this talk: what access and outcome inequities exist in orthopedics? Let's name them, let's identify them, and then let's start to figure out in this, I'll show you the spaghetti diagram on the next slide, but sort of what are the potentially most important mediating variables? Can we identify suggestive correlations that we can target for future investigation for intervention? So this is just to show you, just to highlight that multiply vulnerable patients are multiply vulnerable, that you can imagine how an LGBTQ 22-year-old might not have access to family support for post-op recovery. They might not have access to their parents' car or their parents' insurance to get to an appointment, and how that may sort of snowball for them. You can imagine how an immigrant to San Francisco might not speak the same language, might not have access to a culturally competent physician, and how that can predispose to different post-op recovery issues, and we'll touch on that in the arthroplasty literature. So very briefly for methods, I essentially performed a scoping review. The limitation is that it was just me doing it, and then I sort of picked what I thought were the most common procedures or complaints in each specialty, and then sort of iterated. So I'd take total knee, race, total knee, LGBTQ, total knee, insurance, total knee, socioeconomic status, and just iterated for each procedure across every specialty. I included things that used those factors as a predictor variable. And I excluded things that were irrelevant, not English and duplicates. LGBTQ patients are essentially absent from this talk, and that's not intentional. There's basically no data on LGBTQ status as a predictor variable for access or outcome inequities. And so I think that's a really wide open playing field for growth and for study. These are just abbreviations that are probably familiar to all of us. I'm just including them here for best practice. So let's start with the elective specialties. I'm going to start with arthroplasty. Arthroplasty has the richest literature and the most granular data, and we'll use them as sort of a prototype for moving forward through the rest. I structure it as follows. So in these 4 phases of care, I just imagine taking a hypothetical patient, trying to get them to you, diagnosed, indicated for surgery, through surgery to post-op recovery, and looking at how they recover. And you can just imagine these are sort of suggested hurdles that they may face along the way. So can they get to you? Can they get non-op treatment modalities? Are they indicated equally for surgery? Where are they getting surgery? Are there differences within the operative timing and approach for things like that have clinical equipoise in that context? And then what happens to them after surgery? Do they do as well? What are the mortality rates? What are the complications? So as I mentioned, arthroplasty, I think by the luxury of having only 4 procedures, gets to look into other things very deeply. And so they've done a really nice job laying out the field for us. When we start with prevalence, it is likely that Black men have the highest prevalence of symptomatic knee OA and a higher annual progression of medial compartment joint space narrowing. There are studies that suggest that this difference in prevalence is due to lifestyle issues. So things like obesity and prior knee injury may be contributing there to that difference in prevalence. We know, and some of this work is done by Dr. Zhang in our non-op spine department, we see that insurance status is a barrier to pre-op PT access. So people may not be coming to you at the same level of pre-op boxes checked in that sense, or other treatment modalities tried. And then this is Dr. Ward, Dr. Roberts' data. So distance travel to care. There's a study in Iowa that suggests that Medicaid patients travel further to an arthroplasty surgeon. And then in the database, that the 22 through 24 citations are Ward Roberts data, where they say that higher neighborhood income, white race, and private insurance or Medicare status predict traveling further to your arthroplasty surgeon. I think that those are probably identifying 2 different phenomena that are important to keep in mind as we take that forward. So I think it's likely that what we're seeing is Medicaid patients travel further for any arthroplasty surgeon, whereas more resourced patients travel further to the arthroplasty surgeon. I don't have a lot of additional supporting data, but I think to keep those 2 potential factors in mind as you assess that. As we move into pre-op care, I think this slide is really one of the most important in the talk to sort of carry forward and analogize across the other specialties. So on the right, you see the white-black racial utilization gap for total hips and total knees. Total hip, total knee rates are significantly lower among all non-white race patients, even controlling for age and arthritis burden. It's worsening over the previous study period. You can see that as the lines diverge. Socioeconomic status and area deprivation index account for some of that gap, but it persists in a managed care system. It persists between Black and white Britons in the UK, and it persists for Black and white patients at every strata of insurance status. Interestingly, there was no difference in time to surgery for those who do get surgery. There are a series of really intriguing survey studies with very small sample sizes in the order of like 60, 70 patients, where they ask different patient groups. Specifically, there's one in Chinese immigrants and there's 1 or 2 in Black Americans, where they say, okay, what was it that made you not want to have this arthroplasty, or why didn't you get this arthroplasty? And this is, I believe, specifically for total knees. Chinese immigrants will say, I prefer a racially or culturally concordant doctor, and that wasn't accessible to me. And a very high percentage of patients said, despite interpreter usage, they didn't really understand what the procedure was about, what it was for, what the expectations were. In multiple of the survey studies among Black Americans, again, for a group as heterogeneous as Black Americans, it's hard to extrapolate from a very small sample size, but several factors came up across multiple studies, and they were: 1, I didn't believe that surgery would have a benefit for me. Like, I didn't have hope that I would have a good outcome essentially from this surgery. And then a sort of generalized mistrust that the medical care system would care well for those patients in their perioperative period. It seems to be independent of at-home social support, was also interesting, because you may think of that. But so those survey studies, I think, also really set the tone for some of the rest of the data that we'll see moving forward. We see that Black patients who do make it to the arthroplasty care phase have a longer OR time. It's questionably clinically significant on the individual level, but on the aggregate, maybe contributing to things like infection rate, blood loss, long term. It's on the order of 5 to 6 minutes. We'll see it repeated in sports studies as well. Black patients are younger at the time of arthroplasty. And then another really suggestive data point is that non-white patients are less likely to get surgery at high volume hospitals. And you can see that the sort of odds ratio there on the right. And Black patients are significantly less likely than white patients to benefit from outpatient total joint arthroplasty. These are national data, and I think really important as we start to move into our post-operative data findings, which here are pretty alarming. So the total knee data is consistent. Black patients and Medicaid patients have significantly higher mortality inpatient and 30-day, so early post-op mortality. I did not find data on longer time points, but in the acute phase, we see higher mortality there. We see higher complications, again, among Black, Indigenous, and publicly insured patients, higher readmissions, higher post-op ED utilization, essentially worse outcomes on all of those time points, or on all of those metrics. And we see that Hispanic patients similarly have higher complications and readmissions. I didn't find good mortality data there. The total hip literature is conflicting. So there is higher mortality among Black patients in some studies and the same mortality in other studies. So that's also, I think, an open question, but in total knees, the data is pretty clear. Area deprivation index probably accounts for some of the effects on of race on non-home discharge and length of stay. So just before we move forward, kind of on our whirlwind tour of the other elective specialties, let's recap. Access to high volume centers is not equitable. Access to surgery or utilization of some of our most effective medical interventions in history is not racially equitable. And there are significant increases in mortality after total knee for publicly insured patients and Black patients. So applying that paradigm to foot and ankle, there are no identified racial differences in ankle arthritis by race. However, there is a utilization gap for total ankles, which is the graph that you see here. It's pretty reminiscent of our total hip and total knee gaps, and that is also worsening. We see from the public insurance standpoint that it's hard to get an appointment with a foot and ankle surgeon. There is this group of investigators who did what I think are like my favorite studies in the talk, where they'll call an office with a set of complaints and pretend to be like a foot and ankle patient or a sciatica patient or a carpal tunnel patient and have a series of payer statuses and say like, can I get an appointment with you, and document how long it takes. They typically call on the order of like 50 to 250 practices. So Medicaid patients wait significantly longer, and this is like for an ankle fracture complaint in multiple studies to get to a foot and ankle surgeon. And then we also see a utilization gap for ankle arthroplasty by payer status. So Medicare and private patients are 3 times more likely to get an ankle arthroplasty. As we start to harken back to those complications, infection rates, we see that Medicaid patients take twice as long to get to the OR for an ankle ORAF. Uninsured patients also present later after injury, take longer to get to surgery. So when you start to think about differences in OR time that we see or outcomes post-op, that is probably a significant factor. And then we see that there are differences in election for fusion versus total ankle among Black and white patients. Similarly, we identify higher complications after ankle arthroplasty in Black and Hispanic patients, and higher rates of revision and non-home discharge, which is pretty consistent with our total joint literature. I didn't find evidence for mortality data here or in hand, as you'll see, and I think that's probably because the mortality rates are so low. There's essentially the question had not really been asked. So carrying those pieces forward into hand, we see that it's very difficult to get a hand appointment with carpal tunnel symptoms as a Medicaid patient. So 20% of patients got an appointment at all. We see disparities in the type of diagnostic workup that patients are getting with carpal tunnel symptoms. And we'll touch on this again in spine and in trauma. So Medicaid patients are less likely to get EMG or nerve conduction study with carpal tunnel symptoms. We see time to surgery is longer in Medicaid patients and Hispanic patients for carpal tunnel and for distal radius ORIF. This is just a table showing Medicaid acceptance by practice type, and there was no significant difference in private versus academic. 80% of distal radius fractures are managed non-operatively in this database study. So in order to show an effect size by race in indication for operative management, I think it would have to be pretty large effect size, but there was no difference in that one large study. But we do see that surgical management for carpal tunnel syndrome varies with race, public insurance, and Hispanic ethnicity. So your odds of carpal tunnel release are much lower in that context. Similarly, we see higher complications in Medicaid patients and higher rates of non-home discharge after total elbows. Again, there was essentially no mortality data for common hand procedures, which makes sense given how unlikely it is. We do see that post-op PT referral and completion are lower among lower income patients. So when you're thinking about grip strength, when you're thinking about range of motion outcomes that you might see being lower in those populations, that's a potential reason. We see greater loss to follow-up among low-income patients after distal radius ORAF. And then outcomes after distal radius ORAF in Black, Latinx, and white patients are, in one study, different. So early post-op period, like 6 weeks post-op, people are not doing as well. So Black and Latinx patients don't do as well on DASH scores and pain scores as white patients. Latinx patients have persistently lower pain, higher pain, lower pain scores. At a year post-op, Black patients actually are doing better from a DASH and pain score perspective at 1 year post-op after distal radius ORAF. So as we move forward into sports, we see that it's also very difficult to get an appointment with a sports surgeon as a Medicaid patient. It's a little easier than hand and a lot easier than spine, unfortunately, but it's still pretty hard. And the complaint in that case was first-time shoulder dislocator. We see that Medicaid patients wait significantly longer to get an appointment. And we see that in the pre-op care pathway, rates of indication for surgery and utilization are again inequitable. So this is shoulder arthroplasty by race, again, 3 times the utilization in white patients and worsening. And this, every time I say TSA here, it's total in reverse, just to be clear. And unfortunately, there is not in any of the studies I examined stratification by indication for surgery, so elective versus fracture, which is still arguably somewhat elective, but maybe less elective. And so I think, as I'll touch on at the end of the talk, that's a big clinical question. So is there a difference in fracture versus arthritis, shoulder arthroplasty? It's not clear from this data. We do see that if you're Black, if you're Hispanic, if you have low income, you're on Medicaid, or you have a higher social deprivation index, you are less likely to get surgical management for shoulder dislocation or for an ACL. We see, similar to total knees, that Black patients are getting shoulder arthroplasty at younger ages. And we also see that if you do elect for surgical management of an ACL tear, if you are Black, if you're Hispanic, if you're on public insurance or have low socioeconomic status, you have a longer time to ACL reconstruction. And I think that's another suggestive piece of data, given that we've seen in the arthroplasty literature and also here in cuff repair that non-white patients have longer OR time. So if you think about somebody who's waiting longer from injury or diagnosis to surgery, it may be a more complicated case. We also know that time to ACL reconstruction is associated with meniscal tears being identified during surgery. And we do see, as we see longer time to surgery in Black and Hispanic patients for ACL reconstruction, that they're more likely to have a meniscal tear identified at the time as well. This is Dr. Marks and Dr. Ma's data here. So I don't know if you can see my mouse. Yeah, 70 and 71. So the data is a little conflicting. It's pretty clear that Hispanic patients in multiple studies have shoulder arthroplasty at lower volume facilities. One study identified the same in Black patients, and Dr. Marks, Dr. Ma identified that Black patients are not having surgery at lower volume facilities. So I think that's also kind of an open question, but analogizing to what we've seen in the rest of orthopedics, I think it's quite likely that they do on a national level, not necessarily have access to the highest volume surgeons. And this piece of data is probably the most sobering and upsetting that I found in the whole literature review, which is that the mortality rate after shoulder arthroplasty in Black patients is between 2.8 and 10 times that of white patients. They do experience higher complications, which is partially but not totally accounted for by comorbidity status. When we look at Medicaid patients, the data is somewhat conflicting. So these studies are similarly powered. They're database studies. One is about 90,000 patients. One's about 103,000 patients. The 103,000 patient study showed that complications but not mortality were associated with public insurance after shoulder arthroplasty. The other study of about 90,000 patients identified an odds ratio of 4.6 for mortality in public insurance. Again, analogizing to the rest of orthopedics, I find it pretty difficult to believe that this study is not the one correctly identifying the phenomenon. I think that we probably will see higher mortality in Medicaid patients after total shoulders. But as I mentioned, the big question is indication for these surgeries. And I think we have sort of more granular analysis to do here. So let's use spine as a bridge between our purely or mostly elective and our more urgent, less elective fields. Unfortunately, if you are a Medicaid patient with a lumbar spine complaint, you're going to have a harder time getting a spine appointment than any other complaint in any other field that has been asked as a question so far. So only 8% of Medicaid patients got a spine appointment at all. Public insurance patients from Dr. Zhang's work are less likely to get pre-op PT with a lumbar spine complaint. And then hearkening back to our data in hand literature, where publicly insured patients are less likely to get EMG, uninsured and low-income patients are less likely to get and complete diagnostic imaging for a lumbar spine complaint. And this is just, I believe, from Dr. Zhang's paper, Predictors of Pre-op PT. You can see that the odds ratio for Medicaid is lower. There is a racial utilization gap or indication gap in anterior cervical surgery. However, it is uniquely decreasing. So among other fields where the gap is widening, the rates of unequal indication or election for anterior cervical surgery are slightly converging between white and Black patients. There are survey studies in spine as well that suggest that white patients are more likely to accept surgery, which is similar to what we find in other fields. And then as I sort of start to test my hypothesis about trauma being a different clinical context, there's a study in mostly lumbar spine that shows that white patients are more likely to receive elective lumbar surgery and for lumbar spine trauma. There is a study that looks at trauma in the entire spine, so cervical and thoracolumbar, and found no difference in rates of surgical management by race. So doesn't totally disprove my hypothesis. It doesn't clearly support it. And I think that that is an interesting clinical question that we can look at. So for example, lumbar decompression by indication, so elective versus non-elective. And we do know that non-white race predicts duration of pain before treatment, which when you think about who is predominantly on public insurance and how long it's going to take for them to get to you, if they get to you at all, makes a lot of sense. There are some intraoperative curiosities in spine. I think intuitively we know that insurance status can dictate what cervical procedure somebody gets. We discuss it every year in our spine curriculum, and that fusion instead of disc arthroplasty is common privately. Fusion is more common in publicly insured patients. Again, we see that Black patients and Medicaid patients are more likely to be seen at low volume spine centers. And in these national studies, so not single center, not single surgeon, but national, we see that having public insurance or being a Black spine patient is a risk for dural tear in cervical surgery. So when you start to think about these complications, it makes surgeon and hospital volume even more suspicious to me. This is a lumbar spine study of about 230,000 patients that found that the mortality rate was 11-fold higher with surgeons who had the lowest operative volume. Hospital volume was also significant between the lowest and highest quartiles of lumbar spine surgery performed at that hospital. It was less clearly divergent than you see here with this 11-fold difference by surgeon volume. So our mortality data in spine, again, sort of harkening back to what I was hypothesizing in the trauma context, we do know that lower income is associated with mortality after lumbar and cervical procedures, ACDFs, and also even lumbar decompression and fusion in one of these studies. There was no effective race on 3-month mortality after cervical spine trauma. So again, one time point, and you'll see as I've kind of gone through this talk that the time points of mortality are all different. So I think in order to really see the whole picture, we need to assess at all postoperative time points. So in-house, 30-day, 6-month, 1 year, 3 years. especially in the hip fracture literature, there's differences seen at 1 year versus 3 years or 6 months versus 3 years. So important to kind of zoom out beyond this, but again, suggestive that trauma might be a more unique clinical care paradigm. We do see higher complications and mortality among Black patients and Medicaid patients after lumbar and cervical procedures. So wrapping that up from our elective specialty whirlwind tour and then starting to move into trauma and oncology. As I mentioned, my hypothesis was that this might represent a different paradigm of care. It might be an equalizer in terms of surgeries where there's clinical equipoise or where clinician bias might play a role. Unfortunately, it's not really what I found. So Black patients have a longer time to X-ray evaluation for hip fractures. They are less likely to have ORAF of a hip fracture, which is one of the most adamant, clear indications for surgery we have in orthopedics. We see that with the more elective fractures, it looks a lot more like an elective specialty. So non-white patients, Medicaid patients, those with low socioeconomic status are much more likely to non-op a clavicle fracture. The odds of surgery are 750% higher for a clavicle if you have private insurance. We see longer time to the operating room for multiple types of ORIF in Black patients, clavicles, hips, for those with low socioeconomic status. Interestingly, and so that time to surgery difference is on the order of like 32 hours versus 42 hours, not necessarily clinically significant, but again, in the aggregate, when you're thinking about OR time, when you're thinking about post-op complications and mortality, suggestive. It does seem to vary by hospital type. So again, highlighting the importance of hospital environment as an important mediator. We see that there is a racial difference for time to surgery in community hospitals for hip fracture, but not in tertiary care centers. And that's what's highlighted down here. Black patients are more likely to be seen at academic medical centers for hip fractures, so slightly different care environments. We do know that hospital volume and surgeon volume are significantly associated with mortality and complications here in this clinical context. And so as I move into the mortality data, I'm sort of keeping all of those things in mind. We see that Black patients, Hispanic patients, uninsured patients have higher mortality after trauma, so like a PVA, even accounting for their injury severity scale. And this is data from the National Trauma Data Bank. This difference by race disappears in a universally insured TRICARE population. So insurance, in addition to hospital and surgeon volume, emerging as potentially a really important mediator in this less elective context. In the managed care data, again, we see that mortality after hip fractures at 1 year is similar between Black and white patients. So insurance. In non-managed care, the results are conflicting. It has to do at least partially with sexual dimorphisms. So what you see here is mortality after trauma. So that's the National Trauma Data Bank data from the top left. But after hip fracture, we see that white men have the highest mortality, followed by Black men, Black women, and white women in that order. So sex and race interact in that context. And additionally, the studies are kind of all over the map in terms of time points of mortality after hip fracture. So I think we need to, as I mentioned, zoom out and standardize when we ask that question. So by analogy, I think oncology is similar to trauma in my hypothesis about clinical contexts. This work is largely mine with Dr. Westrak and with Dr. Theologis. So I just sort of included all 4 phases of care on one slide here. But we know that surgical treatment paradigms are different by race and insurance status. So Black patients have the highest rates of amputation for an extremity sarcoma versus a limb salvage paradigm. Excuse me. The amputation rate in Medicaid patients is twice that of privately insured patients for an extremity sarcoma. We know that low-income patients have lower survival. We see higher mortality by Black race and by Hispanic race and by Medicaid insurance status with an extremity sarcoma, even among patients who are receiving the appropriate treatment. So we were able to sort of define like the histology specific standard treatment paradigm and saw that patients who are receiving the appropriate treatment still have higher mortality. That's not true in our spine sarcoma population. So insurance matters, but income status or socioeconomic status and race did not have an effect on mortality in that population. It's unclear to me whether spine sarcomas are so specialized and are kind of always going to end up in the same hospital center or at some point in their clinical course, or whether we just had a type 2 error and missed an association because it's pretty consistent in other cancer data. Additionally, there is data out of the Bay Area Cancer Registry from Dr. Robert Goldsby, who's an investigator here in Peds Hemonc, and is working with us on our sarcoma project as well, that the black-white mortality difference for pediatric sarcomas is entirely accounted for by insurance. So that appears to be true in the peds population, but not our adult population. So I believe what we're seeing here is that cancer type matters, cancer location probably matters. This is a model from our extremity sarcoma paper where extension of disease accounted for the largest percentage of the effect of Black race on higher mortality. Neighborhood socioeconomic status and insurance status each accounted for a smaller percentage, between 7 and 15% each, but stage at presentation was a big cofactor there. So there's a lot of information. Let's see what suggestive correlations we've identified, what conclusions we can draw, and then where we need to go from here. This is just back to that spaghetti diagram to emphasize that a vulnerable patient is multiply vulnerable. I think this data was pretty upsetting for me. I think some of the mortality data, which I've included here, we've seen it at every stage of care. In every subspecialty, race, socioeconomic status, and insurance status matter for what a patient can get and what happens to them afterward. And in every specialty except for spine, the utilization gaps are worsening. We mentioned these increased odds of mortality, which I think should be a call to action. The mediators that are the most suggestive to me across all subspecialties are surgeon volume, hospital volume, and insurance status. I think insurance status is probably the most important of these because especially in the peds population, as I mentioned, and in the trauma population, we've seen that it can account for much, if not all, of the disparate effects or the disparate associations of race with mortality. Time to diagnosis, stage of presentation also seem to have a pretty big effect. And to me, those are access to care variables. Comorbidities, patient preference may play a role in those really suggestive survey studies. And I think that's also a point in which an individual clinician can have an effect by being aware of those themes and really partnering with patients, making sure that patients feel supported, that they believe that they can be well cared for, that some of our most effective pain relieving and function preserving surgeries would be of benefit to them. And so in terms of intervention points, I've broken them down into the individual physician, the program practice, and the policy levels. So as we were discussing on the individual physician level, I think recognizing that especially your low income, your public insurance patients are going to have a harder time getting to you. They may not have had the same access to non-op treatment modalities or diagnostic imaging before they get to you, and trying to internalize that as a system problem and not a problem of the person in front of you being non-compliant. I think one really specific granular thing we need to be doing is referring more Black women for DEXA scans when they come across our exam table. I think performing individual bias assessments is important. And then, as I mentioned, the two most important things. So I think we have in our power to perform high quality granular research with multivariate and mediation analysis, targeting some of these variables like hospital surgeon volume. I think additionally, as I mentioned, making sure that you're really partnering with each individual patient and assessing their understanding of surgery, especially as we know that we can be doing better in the Chinese immigrant population, which is really relevant for care here in San Francisco. On the program and practice level, so we've seen evidence for race concordant care having a mortality benefit in other areas of medicine. And I know that we have had an increased focus on DEI and underrepresented minority recruitment and retention. As I mentioned, I haven't seen data from the last 5 years, but I think it's essential, especially because we see patients who have a preference for race concordant, culturally concordant care, and that may be making the difference for them in terms of electing for a really beneficial surgery. And then on the practice level, if you accept Medicaid, if not, why not? Because those patients need you, and they need your specialized high volume care. And then on the policy level, I think what we're going to identify more of is that housing segregation is begetting medical segregation, as we saw in the case of access to high quality mammography screening machines in breast cancer. We see repeatedly throughout this talk that patients of color and patients on public insurance do not have access to the highest volume surgeons that may have the lower complication rates, lower mortality rates. And finally, as I've harped on, insurance access. So I actually just ended this with a whole bunch more research questions. I'm happy to hand them over to people or collaborate on them with anyone. I think the single most interesting and important study that we could do pretty simply now is total hip by fracture indication versus elective indication, and looking at racial and insurance differences in mortality between those two contexts. So similarly, you should and could do that with shoulder arthroplasty. So fracture versus arthritis, and then racial differences in mortality. And you got to look at all time points that are available to you in your database. Lumbar decompression is another procedure that I think could be pretty similarly analogized between an elective and a trauma indication with the same questions. I think that you could ask questions about race concordant care and seeing whether they had a mortality benefit in those contexts. As I mentioned, LGBTQ status is a wide open field for clinical question in terms of whether those patients are predisposed to worse outcomes in orthopedics. I think scaling up those patient perception surveys to be more generalizable, because as I mentioned, they're pretty small sample sizes. And it's really hard to generalize in a population as heterogeneous as Chinese Americans or Black Americans. I think it's probably a pretty difficult study to perform, but it would be useful information. Yeah. And then whether having a racially or culturally concordant provider is going to decrease inequities in rates of indication for the elective surgeries. Thanks for having me.
Right. Thank you, Dr. Stroud. That was wonderful, and a lot of great information. A lot of hard work clearly went into that, and definitely an important topic. I see a hand up from Dr. Westrak.
Sarah, thank you so much. That was excellent, and you put so much work into that. I hope you are writing a review article. Is that correct?
Aviana and Jen and I are drafting one with the spine data with Dr. Bourbon. It's in drafting stage. It'll get there.
No, I mean,
yeah,
you have to.
Yeah.
Sorry, this is a direct order. That must become a paper. That was
Okay.
great.
Thanks.
My question is, did you find any data on the utility of either patient navigators or nurse navigators for vulnerable populations? And how does that improve or change? Does it change any of these outcome measures?
Yeah, I didn't. I know that your department is looking at some of that, and with language concordant care, right, or access to translators. I think that's a really good question, especially in the immigrant population or in people whose second language is English. I think maybe for the Medicaid population as well, in those more resource intensive settings like sarcomas, but I didn't find any specific data.
Because I know, we all know the medical center is trying to figure out, are there ways that they can support efficiency and practice and getting patients, to the operating room. And one thing that did come up in one of our meetings was nurse navigators. And I wonder if a targeted effort within subspecialty care or maybe even within primary care would be helpful to get all patients the care they need in an expedited fashion.
Yeah, I'm sure that it would.
It's a really important talk. Thanks for all the points you brought up. I agree with Rosie. That does need to get into the literature. I think we need to activate a few more evening meetings. Having said that, do you have any information specifically? You talked about Medicaid primarily and public insurance, but what about reimbursement models for physicians? So, for example, a lot of certainly here at UCSF, we're reimbursing a funds flow model compared to a revenue model. A lot of other practices have moved into that. Has there been any work done on the correlation between reimbursement model, for example, an accountable care organization, a fund flow type model based on RVU payments versus a pure fee-for-service economy, or whether or not that it might impact physician behavior?
Yeah, I think there is in the arthroplasty literature. I didn't delve into it too deeply, but arthroplasty surgeons, there certainly were a few articles I came across. I didn't delve into them.
Certainly, this is a reflection of part of what I talk about a lot is maladies or a fee-for-service healthcare economy. If we're looking purely at reimbursement, that's where the private payers become, that's where the differential and the gap and the gradient becomes greatest.
No, I mean, thinking about research, is there a difference in how the orthopedic spine and the neurosurgery spine are reimbursed? Are they both WRVU based, or is one fee for service and one not? Okay.
Right. So you mentioned that Black people are younger when they get total hip or total knees or total shoulders.
Mhm.
And then one of the things you hypothesized was that might be comorbidities, injuries previously
In the knee literature, yeah.
in the knee. What
Mhm.
about for shoulder? Because if there's an access to care issue,
Yeah.
which there obviously is,
Mhm.
why are Black people getting shoulders at a younger age rather than an older age?
Yeah, I think that's a good question. And I know Dr. Shapiro in hand is doing some work on like age of 65 and demand for arthroplasties after 65, meaning people are basically, it's pent up demand is part of the idea that's happening. I don't know, I don't remember off the top of my head whether it was like a pre-Medicare, post-Medicare age difference. So it may be a factor of just post-Medicare pent-up demand being in that population who gets Medicare and has had an injury and has not been able to see you for their shoulder dislocation at age 22 and now has arthritis.
No, they can see me. That's a good point.
Yeah,
They weren't
good.
being seen early on.
Yeah.
They developed early OA,
Yeah,
and then nobody really wanted to treat them because they were too young until
yeah,
they weren't too young.
yeah. That's my theory, but I have zero data to support it.
Hey, great talk. I don't know if you mentioned this or maybe if I missed it, but did you find any data on like the number of available subspecialty surgeons for different insurance status? Like, could some of this just be, could a lot of this be fixed by more people accepting Medicaid, or is that not really what the issue is?
No, I think that's the issue. I think that accepting, I know we accept Medicaid at UCSF, Medi-Cal at UCSF, which is great. So it's a little less relevant for us. And again, interestingly, in one of the studies by that same group who's just like pretending to be a patient with every problem, they found that there wasn't a difference in Medicaid acceptance by private and academic centers. Yeah, I think that that's probably the operative variable there.
And was there any like specific data on like, is it like 1,000 patients with private insurance going to like 30 surgeons versus 1,000 patients going to like 5 surgeons? Was that?
So the way it was done was they would get together and they'd say like, I have numbness and tingling in these 3 fingers. I need to see somebody, and they'd call like 60 hand offices or 240 hand offices, like in that range of numbers, in like some mile radius. I think they're also geographically clustered is probably a limitation with some of these studies. And they'd say like, will you give me an appointment?
Excellent talk, Sarah. Really important topic, certainly a lot to unpack in all those specialties. But early on in the talk, you pointed out the fact that there are differences in outpatient utilization rates for folks getting total joints.
Mhm.
And I know we don't do a ton of those here, but I imagine one day that number will pick up. What thoughts do you have in terms of how we can prevent ourselves as an institution from becoming a part of that same, perpetuation of those disparities?
Yeah, I mean, I think, like I said, on the individual provider level, it's really important. I mean, our best data from these survey studies, especially with Black patients and with Chinese patients, is in arthroplasty. And we are not doing a good enough job communicating in English or in Chinese with our patients and saying, this is a really effective pain relieving surgery. It is going to treat you well. We are going to treat you well. We're partnering with you. And I think in high volume clinic days, it's probably hard to have that conversation 30 times, but it's really important because on the national level, on the aggregate, we're failing patients by not offering them, or I don't want to, obviously you can't push somebody to surgery, but in terms of communicating how useful and helpful these surgeries are.
Thanks. Sarah, I just would follow up on that, and first, compliments on well presented and comprehensive. And I think you got a lot of people thinking about these issues.
Sure.
And as I listened to you, I thought about, the topic started out with access to care, but ultimately it's really about quality of care. And it shouldn't be surprising to us if certain groups elect not to have a procedure when the outcomes aren't as good. And we really have to focus on, if we can provide concordant care, can we provide care that is of standard quality, so that the expectations are there, and then we can assure any group that comes in that if with concordant care, with the same access to quality, that your outcome will be as good. And I don't know that we can say that right now. We need more information. Question would be, did you encounter something that was just totally obvious, where the outcomes are equally good, but there's the disparities in access are unexplained by that?
Yeah, I mean, I think, to me, having gone through all of these subspecialties and all this data, I think that, as you're highlighting surgeon and hospital volume, the experience of the surgeon in performing the operation, so in spine, in not getting a dural tear, right, and the experience of the hospital post-op in caring for that patient who had a dural tear, are going to be really important. And that's obviously more of a national, like, who is going to which hospital problem. I didn't really present any data except for in hand about pain and function post-op. So I can't say for sure that patients who are non-white have worse functional or pain outcomes after any surgery other than a distal radius fracture, at which time point at a year post-op, Black patients are actually doing better than white patients. So in terms of that type of outcome, like pain relief, I think that's separate from your point about mortality. So I agree with you. I think essentially we just need more granular analysis.
All right. Thank you, Dr. Stroud, again. This was wonderful. And thank you all for being here.